Welcome everyone to our afternoon session on internal medicine. I'm Alan Roussel from Texas A&M University in the United States. Just want to take a minute to remind you to look around and see where the numerous emergency exits are, and also to ask you for as a courtesy to our speaker and to those around you to please silence your cell phones if you happen to have one. Our first speaker, our keynote speaker this afternoon is Dr. Peter Constable, who's now Dean at the University of Illinois. He hails from Australia and did his advanced training at the Ohio State University. Peter and I kind of grew up together in internal medicine in the United States as contemporaries, so I've known him a long time, and many of you probably know him for his expertise in acid-base balance and strong ion difference and cardiology and the like. He's probably one of the most intelligent and analytical and intellectual people that I know, but at the same time, he is very practical when it comes to his approach to treating individual animals and handling medicine cases. And today, he's going to talk to us about a very practical subject about cow, and he's coming, he snuck up on me out there. He's going to talk to us about cow-side diagnostic techniques and what we can look for in the future. So help me please welcome Dr. Peter Constable.
Good. Thank you very much, Dr. Roussel, for that generous introduction. Thank you very much for World Buiatrics Congress 2016 organizers for inviting me to speak. I've really enjoyed the Buiatrics Congresses over the years, and this one has been as outstanding as many of the ones before them. And I hope to share with you over the next 40 minutes a little bit more my passion right now, which is for point-of-care, low-cost, accurate, practical testing for veterinarians. If you look at the revolution undergoing the healthcare delivery system around the world for humans, one of the big emphasis is on future development of low-cost, easy-to-access point-of-care tests that will help you diagnose and direct treatment. So what we really want is a test that can immediately impact the way that we are handling patients. This is a lot easier to implement in veterinary medicine because we don't have the same insurance challenges on the healthcare side and also the litigation issues on the healthcare side with the need for voluminous documentation of patient care records. I'm not going to go through all the point-of-care tests that are available. I'm going to instead talk a little bit about the general principles of what might be a good test, what might not be a good test. When you hear them talked about at other meetings, when you go down into the conference arena downstairs and talk to the exhibitors, there's a number of great point-of-care tests that they are promoting. It'll give you a little bit more information to ask them questions to decide whether this is the right test for your practice at this time. So I've already mentioned the biomedical engineering advances, very, very important and a very focused area right now. But from the veterinary side, this will improve your practice quality because if instead of being puzzled about what this case might have, deciding that you need to get additional information, which might be a blood work that you might run back at your practice or that you have to set off, wouldn't it be a lot more satisfying if you were able to get that information on the farm and therefore not just guess on what would be the optimal treatment modality, but actually have a little bit more confidence? The producer then, I think, will pay some additional money for this because they'll perceive this as added value to the visit. It's a faster, more accurate diagnosis, and it might prevent additional revisits to the farm. So some of the specific issues related to this, and there's already been a number of great talks at this Congress about point-of-care tests, and I was interested to see that we're all coming up with the same sort of list and the same sort of priority. But obviously the test has to have acceptable accuracy. Now, it doesn't have to be perfect. In fact, there is not the perfect test out there. But given all the other things that we're interested in about the test, it has to be reasonably accurate. And we'll talk specifically about a couple of key statistical issues you need to look at, particularly area under the ROC curve. We'll talk more about that. Obviously, the cost of the unit, and then once you've purchased the unit, the cost per test. They're going to be very important factors as to whether we even use this test. Ease of sampling. There's a lot of interest right now with thermography because that is without really interacting with the animal if the environment permits you to take thermography very well. A milk sample probably needs the least amount of skill to obtain compared to urine sample, compared to a blood sample. Well, the blood sample, now you've got sharp needles that can occasionally get lost in a cow's environment and create some other problems. Time taken is an important issue. Very, very important. Can you actually truly do this cow side, or do you have to take the sample back to another area that may need to be climate controlled? That might not be available on all operations. And then a big issue is, has this been validated for use in cattle? Now, we're all mammalian biologists as veterinarians, and we know that there's a lot of comparative differences between animals, and we know there's a lot of similarities. So sometimes it's reasonable to assume if this works in a dog, it's going to work in a cow. And other times it's not reasonable to make the assumption. And I'll give you a couple of specific examples on that so that when you hear about some of these new tests, you might say, well, that'll probably work in cattle, or I really want to wait and see the validation data before I go ahead and do that. And that gets into methods comparison issues. So when you look at how to evaluate, it's not just good enough to write a paper and say that this test is significantly different, because that's not how we use the tests. We use the test for usually diagnostic purposes, or potentially, I'm not going to talk much about therapeutics today, but we need to know with that target population. So for instance, if I had a test to diagnose mastitis, it's not much good me validating that test in bulls. That's not going to be the intended population for that evaluation. So the three critical things that we really need to know, and when people are promoting these tests, you should really be asking me, what's the test sensitivity, specificity, and what is the area under the receiver operating characteristic curve, which we call ROC curve. So if the area under the ROC, which is plotting sensitivity versus 1 minus specificity, what we really want is we want a curve that comes as close up to this top left-hand corner as possible. If it does that, that says the sensitivity here is 1, and 1 minus the specificity is 0. That is the perfect test, which does not exist. If we have a coin that we flip, and I can sell you a 1-cent coin for $1 if you like, and say that this is a diagnostic test, its test characteristics are characterized exactly along this line. So if I'm going to say this cow has this disease or not has this disease, I can just flip a coin and say heads, and I'm going to be on this line. So what we want in a useful test is we want as much area under this curve as possible. Now, what you'll find with most diagnostic tests that get written up in journals and that you will see sold is that the area under the curve here is somewhere around 0.7 or 0.6, which is enough to attain statistical significance, but is very close to worthless clinically, because it doesn't give you that much more information than probably your gut instinct as an experienced practitioner should tell you. So when you look at this area under the curve, we would love that to be 1. It never is. In the real world, almost all the good tests that we're using have an area under the curve above 0.9. So it's somewhere around this area right here. So what that means is a lot of the time this test is going to give you a useful answer. Many of the ones in journals are around 0.6 or 0.7. I think really for me to feel comfortable with any of the diagnostic tests I've been working with, I really want an area under the curve above 0.8. And then remember, if it's 0.5, that is flipping a coin. So it's really no better than chance alone. And there's a lot of work being done on this just in the last 10 years, and there's becoming this real consensus about the best way to evaluate this is area under the curve, the ROC curve, receiver operating characteristic curve, which is this plot, and we want that ideally to be above 0.9. Sorry, let me just, okay. All right, so if you want an ideal of the perfect diagnostic test, that's the California mastitis test. So this is not a new concept. This test has been around since 1957. And why is this the ideal test? Well, it's reasonably accurate. It's not perfect, but we're interested in picking up inflammation. Inflammation should have increased leukocytes. When you get an increased somatic cell count in milk, most of that is leukocytes. And this test works very, very well because we can absolutely do this cow side, get the results back in 45 seconds, and we think that this material is non-toxic to the environment, so you can just easily dispose of it. And the cost per test is a couple of cents. So when you start looking at these other tests, start asking yourself, how does this compare to our California mastitis test, which is really the gold standard on this behalf? So this is not a new concept. I've put up here some of the key references on this over the years, but really it only started in the last 12 or 15 years, there's interest in these point-of-care tests. But I do want to draw your attention to Professor Altman's presentation here at the World Buiatrics Congress 10 years ago. At the University of Liège, they've developed a wonderful van that they use to help teach their students. So this goes out on ambulatory calls. It's very, very well equipped. This is the van parked, and this can do a lot of these point-of-care diagnostic tests on the farm. It can do even a little bit more than what most veterinarians are doing because it's got a centrifuge and some other things. So you have to sort of make your own mind up as to whether you want to go to the centrifuge level, but there's quite a few tests you can do that you don't need a centrifuge. There are some other publications on that, including a very recent one in practice, listing quite a few of the point-of-care tests that might be of value in your practice. So let me just give you an example of some of the studies that we've been doing very recently. Some of these are in press, some are about to be submitted, but none have really been published and they really haven't been presented at a wide audience. So I just want to give you an idea about what is on the horizon. So this is a Japanese company called Horiba that have been making portable pH meters for many, many years. And they've used their expertise in that to get into what's called ion selective potentiometry, which is that you have a material that can allow potassium or calcium or sodium to transfer through the material, but no other cations, and from some complicated engineering can give you an idea about what the concentration is. So we've been working with these for about 3 years. This was their initial prototype. And they've now slimmed this down into this pen size idea. So this is a little bit bigger than a pen. And this unit right now costs about $280. And for the reagents and the lifespan of the electrode ends up about 10 cents a test. But now, for the first time, we actually have a test we can use cow side to see whether a cow has hypokalemia. So you're called out to look at this down cow. The farmer's already given her 2 bottles of calcium. The cow's not getting up. You're out there doing a very thorough physical exam. You agree that it doesn't really look like a classic milk fever. It would be nice to know whether this could be a hypokalemia down animal before you try and lift it and then look for more nervous damage and other issues. So this study is in press right now, and you'll be able to see it in Journal of Dairy Science. But we went ahead and validated this Horiba unit for use mainly for blood, but also for plasma. We looked at its ability to test potassium in milk, abomasal fluid, also urine. And we used quite a few samples for this. So some of these were stored samples from previous studies. Some were animals where we had quite a nice range of potassium concentrations, and then similar with urine samples. So I'll just give you an idea about how you should see this information presented on a methods comparison study. You must see 2 graphs, one of which is what we call a scatter plot, which puts your test unit on the y-axis and the gold standard or reference on the x-axis. And then you should have a horizontal line that says, a diagonal line that says that this is perfect agreement. So if all the dots ended up on that line, that was a perfect test. So in this particular instance, we're using a Hitachi as also ion selective electrode as the reference method. And we've got some low potassiums down here, certainly under 2. One of the weaknesses with this study is this is in adult cattle where we don't see high potassiums that much. So this study needs to be extended and done with calves with hyperkalemia to see how aggressive you need to be with your treatment. So that's the first thing they need to present. The second thing they need to present is what we call a bland Altman plot, which is where you look at the difference between your test and truth sample on the y-axis versus the mean of the two, and you hope that they all cluster around 0. So this one, they cluster around a little bit below 0. In fact, it was 7.3% lower. Now, this actually is perfect agreement because without getting into a lot of the science, this actual measurement fudges its result up by 7.3% through a calculation to correct for the typical plasma protein concentration. So without that correction factor, these actually would be in perfect agreement. The third thing you want is this analysis can't just be by typical linear regression. What it needs to be is to do a specific type called Deming regression, and then there's another form called passing Bablock. They're the two that have to be used. If you use linear regression for this, that's statistically illegal, and you're going to go to statistical jail for doing that. So the good advantage about this test is you can do this on whole blood. So you can just get a drop of blood from the coccygeal vessels, put it on the test, and get blood, and if you compare that blood to plasma, it's perfect. It's along the line of identity. There's actually 369 data points right here, but many of them are superimposed, as you can see over in this area right here. But this deviated by 2.1%. Interestingly enough, that's exactly what happens in humans when they test blood versus plasma on this, and it's not due to hemolysis of the blood as it drops down onto your meter. It's unknown as to what the cause is, but it's a constant thing. So right now, this Horiba test looks tremendous for serum and whole blood as an index of plasma or blood potassium concentration. What about some other fluids? So this is avomazole fluid, not something that we use diagnostically very much, but it might be just representative of whether it had any utility for rumen potassium concentration or anywhere else in the GI tract. And you can see here that this is excellent agreement. Right along the line of agreement, bland Altman plot actually showed no difference whatsoever. So this is perfectly validated for use, at least on avomazole fluid, and we're going to extrapolate that and say maybe GI fluid. What about in fat-free milk? So there's a lot of interest in can you look at milk potassium and as an index of whole body potassium stores. It doesn't look like it's as good a test as you might, at least on first glance, thought it might be. But this looks like this is a pretty good test as well. It does measure 3.6% lower, but that is the protein concentration of milk in this herd. And if you adjust it for that component, because that is not what water is dissolved in, if you have a liter of water with a typical 70 grams per liter of protein, a liter of plasma with a typical 70 grams per liter of protein, you only have 930 mils of water. So this adjustment right here is exactly on board. So again, this is validated for use in milk. Urine is interesting, and this is a good example about why you've got to validate this instrumentation. This is used widely in humans and dogs, works perfectly. Does not work in herbivores, horses, llamas. There seems to be some what they call a zwitterine, which is a positively and negatively charged ion that traps the potassium and doesn't allow it to be sensed by the ion selective electrode. And this is random, so a lot of cows' urine works well, but then there's some where this meter under measures. So I would not suggest use of this meter for measuring urine potassium, but if you wanted to use it, you should know that it could never overestimate the urine. It's either the urine potassium is either what it says it is, or it could be a little bit higher. Sorry, I didn't say underestimate. So how might you use this clinically? So a good example is following clinical mastitis to see how the speed of resolution is going on, or even as a potential cow-side test for subclinical mastitis. One of my PhD students is currently looking at 28 different tests for subclinical mastitis, and milk sodium and milk potassium are coming up as extremely promising cow-side tests because they're low cost, very sensitive, and look acceptably accurate. So here's just as an example study of one of my other PhD students did a study with inducing mastitis in goats. When you induce severe mastitis, you get breakdown of the blood-milk barrier. So the sodium concentration in milk is normally 21. As you know, in plasma, it's 140. If you have damage and breakdown of that, 140 will drop down to 21. So the result is that your milk sodium concentration will go up. So Hoof also sells a sodium meter as well as a potassium meter. And here is just an example of these changes with experimentally induced mastitis. So the sodium concentration is normally around 25, 23, 25. In the control, uninfected goat stays constant. With experimental induction of mastitis, you can see it's massively high, 80. So it's starting to get almost close to what it is with serum. And then this animal clinically got better by the first 24 days and was actually clinically normal at day 96. And that was also supported by the sodium concentration. Now, a previous forerunner of this that you might have been aware of is electrical conductivity. That is not as good a test as sodium because it's testing really sodium, potassium, chloride, and maybe any other potential anions that are in there. And you can see the discrimination is not quite as good. But the potassium is interesting in that normally it's about 40, 43 milliequivalents per liter in ruminant milk. And it stays low with mastitis, but stays low for longer. So at the moment, with our data set, it's actually looking like milk potassium concentration might be an excellent test for subclinical mastitis. So we're not the only ones working on this. There's quite a bit of interest in these types of tests because this actually could be automated and put in the parlor to give you an idea what's going on also with robotic milking. All right, so we've got some good examples. Now, the same issue is, wouldn't it be wonderful if we could do the same thing with a calcium meter? So Hoof has just changed the scale on the calcium meter that they had, which usually could just pick the lowest level of that. Used to be just at the point of subclinical hypocalcemia, and now it's lower. So we're in the process of validating this calcium unit as to whether you can put a drop of blood on the end of that unit. You don't need to calibrate this every day, so you can pretty much pull it out of your pocket, put a drop of blood on it, in 45 seconds you get the value, and that can tell you where the calcium is in that animal and help you provide a more accurate treatment. All right, let's change to a different area right now, parturition. So I've been very interested for many years in being able to accurately predict when is this cow going to calve. It might be it's a very valuable embryo transfer calf. It might be the dam is worth quite a bit of money. For Belgian blue industry, this is very helpful because a lot of these are being delivered by cesarean sections. You can see this is quite a substantial calf that with all this muscular hypertrophy would have trouble being delivered safely. So they've been interested in this for a long time. Can you predict that this cow is or is not going to calve in the next 12 hours? So therefore the producer may be able to get more sleep than they would otherwise. Another reason to do this is I believe that it's more advantageous to give oral calcium solutions before calving than at calving. All the studies that have been done to date have given them after calving because of the difficulty in accurately predicting the time of calving. So the gold standard has been plasma progesterone concentration because this is the upstream initiator of parturition in cattle. So the fetus is getting stressed because it's not getting enough nutrients. Its response to stress is to increase fetal cortisol. That does not cross the placenta, but it changes the placental metabolism of progesterone to estrogen, and as a result, placental production of progesterone drops, and that starts removing the block on myometrial activity, so we start getting uterine contractions and prepare the animal for delivery. So the most upstream change is an initial drop in plasma progesterone that happens about 36 hours before parturition. So that should be the thing that we test. So you can pull a blood sample, you have to drive it back to your lab, you then have to spin it in centrifuge, and then use an ELISA plate reader and do it in duplicate, and that costs about $6. So that's definitely not cow side, but to give you an idea, this is the current gold standard test, but the area under the curve is 0.93. So we would love that to be 1.00, but it's not, but it's above 0.9. So this is a clinically useful test. And you can see the other guideline you should look at is ideally you'd like both sensitivity and specificity to be above 0.8. A lot of the tests that you see being promoted, one of them's not going to be above 0.8 because it's hard to get both of them above 0.8 for a lot of these tests. So you can do then a lot of very complicated statistics, which I won't go through, but ultimately we generate a probability curve that we have here over on the right, and the optimal cut point here is 4 nanograms per mil. So if I get a blood sample, I run progesterone on it. If it's under 4 nanograms per mil, I've got a pretty good chance that that cow's going to calve within the next 12 hours. So that's really a gold standard test that we might have. So can we get something that's more practical? Might not be as good as that, but it might be something reasonable. So we've been very interested in looking at alternative tests, and plasma glucose concentration is looking very promising. So what we are using here is the Precision Extra, which is called the Optimum Exceed here in Europe. This unit costs about $30, and the per test cost is relatively low. I think I might have it on the next slide. But you put a drop of blood on the unit, and why this works is because as the dam has progesterone dropping and it starts getting maternal contractions of the uterus, that is starting to be uncomfortable and cramping, and as a result that induces a cortisol increase in the dam. That cortisol increase in turn causes glucose to go up. And you will see here on every 12-hour bleed of about 100 cattle that you will see that the glucoses go up about starting a little bit under 24 hours before parturition. They peak immediately after parturition, then they rapidly fall. So this has been known for 30 years, but people really haven't explored this as a potential way for predicting parturition. So when you do this, our ROC right here is 0.83. That's pretty good. That is the second best ROC ever reported for predicting parturition in cattle. Much better than a whole lot of other indices that people have talked about: sciatic ligament relaxation, dripping of milk, turgidity of the udder. And so the optimal cut point right there would be 72 milligrams per deciliter. So you could just take a blood sample every 12 to 24 hours. If it's above 72 milligrams per deciliter, with reasonable confidence but not certainty, you can say this cow is likely to calve within the next 12 hours, then you could increase your level of scrutiny on that animal or administer milk fever preventatives if that's what your interest was. Another interesting one is rectal temperature. This is done a lot with the Belgian blue animals in Belgium. The animals are housed in a constant environment. They go along and have their temperature taken, those that are within the last week or so of calving. And what happens that you'll see right here is starting about 24 to 36 hours before calving, there's a drop in rectal temperature. Why? If you remove progesterone, interestingly enough, that drops metabolic rate. When you inject progesterone, you increase metabolic rate and you actually increase temperature. Also, these cows terminally start to back off feed, so the heat of fermentation, which contributes a little bit to rectal temperature, goes down. And then there is the exertion associated with parturition increases the temperature right here. So this is not a spectacular decrease, but it has been used in a number of farms. Our ROC here, 0.74. In the range that it might be a useful test, but it's not as good as the blood glucose that we just showed. And this would say if the rectal temperature was under 101.1, then there's a decent chance that cow's going to calve in the next 12 hours. One of the real challenges with this is when you start getting into hot environmental conditions, this gets confounded by hypothermia just due to high ambient temperatures. This is done routinely by using these fast-acting, expensive thermometers, and these are $550. But you could get the cost of that down if you used alternative thermometers. So let's move a little bit more and say, okay, we predicted parturition. I'm also interested about whether this animal is going to have dystocia. So this was another area we looked at related with on-farm diagnostic tests. And we did publish this in Theriogenology last year. So pelvimetry is a controversial area. There are people that are very much enamored with measuring the internal pelvic diameter. There are other people that say when you do that at breeding or shortly after breeding, that is so far off the growth curve for heifers that the predictability 9-10 months later is close to worthless. So I'm not going to get into that argument right now. I was interested in, I know this dairy heifer is going to calve next week. Why don't we measure her pelvic dimensions right then, and then there's this no issue about what it's going to be in 9 or 10 months. We know what it is. And it might be you might choose the heifers that look of smaller stature, and then you couple that with some information about how big is the fetus. So there was a very nice poster yesterday downstairs that looked at this exact same approach, but they ultrasounded the width of the fetal foot coupled with pelvic measurements before calving as a means for predicting whether or not you're going to have dystocia. So for this technique, we're using a rice pelvimeter. That costs about $200. And what you do is you pass this into the rectum and then open this up vertically and also horizontally, and you measure those two dimensions of the pelvis. You multiply that together and you say that that is the pelvic area. So what is different about what we did here is we coupled this with measurement of the fetus hoof circumference. So there are commercial tapes that are available, sell about $7, but you could just use a dressmaker's tape because all we're measuring here is front foot circumference in centimeters, and you can see that this is associated with calf body weight. The one weakness with it is here, you can see there's still quite a bit of variability in that prediction. So it doesn't just say that the calf's going to weigh 40 to 42 kilograms. The range is much bigger than that, which weakens the utility of this test. So we did both of these things. We measured internal pelvic dimensions before calving, a few days before anticipated calving date. For this study, as soon as the calf was delivered, we measured coronet measurement, but in a perfect world, new veterinarians that still haven't calibrated whether they think they can deliver this calf or not could actually measure this as the front foot is being extruded from the perineal region. So why I like this is because as a veterinarian, we've all been there with dystocias, and the producer forces you to make the decision to do a vaginal delivery or cesarean section. So wouldn't it be helpful if you had some probability? So what we have developed here is the ROC curve is 0.81, which is getting decent. It would be nice if it was greater than 0.90, but this is a decent test. Specificity is pretty good, but sensitivity is not that great. And what that says is, at least from the cow side, maternal side, if the pelvic area is less than 270 centimeters, we're going to have a serious dystocia. And this was a two-person pull or mechanical extraction or C-section. That's how we define dystocia for this study, which involved 106 cows. If you looked at the best predictor just from the calf data, there was nothing that was predictor of a dystocia. So what that tells us is you can't just look at the calf and say this calf can or cannot be delivered. But when we put the two areas together, which is the ratio of the calf foot circumference to the dam intrapelvic area, this actually was a decent test. And if you actually, an even simpler way of doing this is look at the ratio between front hoof circumference to pelvic width. And if it's greater than 1, which is what all this math comes up to give you a calculation of, it's got a chance of 50% or about 55% of being a severe dystocia. So you can have this table laminated with your calving box. You can tell the producer, let's say that when you started, the calf was not engaged in the pelvic inlet, you could get an accurate pelvimetry measure, and then you could actually get a foot circumference. You could tell the producer that right now, based on this information, we have a probability of severe dystocia of 20%. Do you want me to pull this calf? Or you can tell them it's 80%. Now, the other thing that needs to happen here is this needs to be compared to experienced practitioners, which I suspect this experienced practitioner can outperform this, but it might be very helpful for new veterinarians. Another interesting test is looking at urine. You open up any small animal textbook, they'll tell you you can't look at the urine and see how dehydrated the dog is. Well, humans don't believe that. There's been a number of studies looking at wrestlers and says that yes, you can look at the color of the urine and tell how dehydrated they are. So we just got a urine sample from over 1,000 urine samples, and we just looked at the color, and we used a color coding system here using paint strips from the local hardware store. We then looked at the pH on these strips. We looked at specific gravity as the gold standard. We've also done this with osmolality, but specific gravity using two types of refractometers. There are new digital refractometers out here that work inside barns. You don't need bright sunlight to help you read them. We also measured electrical conductivity using 2 units to see how they worked, and then we also compared that to color. So on the pH side, which might be interested if you're looking to control milk fever with dietary cationic difference, we might want to target a herd average urine pH of 6.3. How do you do that? Well, you can buy these multi-sticks for 36 cents each and look at the pH on that, and you'll see this is a pretty good test. On average, it reads about 0.3 pH units high. So if you're using these, just take 0.3 off it, and that's true urine pH. A cheaper way is to buy these pH papers that have a range from 0.2 to 0.3 pH units and ends up at about 2 cents per test. And these actually work better than the multi-sticks. As you can see right here, pretty good performance right around pH of 6.5, and the bias there was reading under by about 0.1 pH. So you could add 0.1 pH unit on average to the measured value there. So this is very practical for monitoring feeding acidogenic diets. What about the color? So this shows very conclusively that as the urine gets darker and darker, it gets more and more concentrated. So this is something you can teach all your producers, that if they start seeing cattle producing very dark-colored yellow urine, they're probably dehydrated, and they probably need to do something to address that level of dehydration. The other interesting thing is the multi-sticks does have a specific gravity unit on there, that you can use, but it's an extremely poor test of specific gravity. So there's something on the multi-sticks that we've gone ahead and shown is of no clinical use. So I just want to finish up, let's see, I'll just skip through I might go back with beta hydroxybutyrate because this gives a very important illustration. There's been a number of calibration studies on beta hydroxybutyrate in cattle. Every one of them has pretty much been flawed. Why? They didn't have a big enough range of values to explore whether the meter performed very well. They didn't measure temperature, and they didn't actually do classical methods comparison studies. So in this particular one, we had a very wide range of beta hydroxybutyrate concentration by the reference method up to 9 millimoles per liter. That is a really very, very sick ketotic cow, and we're starting to get to see fairly high mortality with hepatic lipidosis right there. First thing I want to show you is that it's not linear. Once it gets past about a true value of 3, which on plasma was a value of 5. And this has been documented in 6 different studies in other species, but has been ignored in cattle because they didn't have this type of range. The second thing is most people have just measured this from about 0.2 to about 2 in blood. And you can see here in the open circles it's sort of working okay, but still not perfect. In fact, this is the blood right there on the middle panel right there. You'll see that it is not measuring perfectly, but we had a bigger range than what most other people have seen. I just want to finish up on this particular example because the real problem here is this unit was designed for humans, and the intraerythrocyte beta hydroxybutyrate concentration is much higher in humans than it is in cattle. This has been known for 50 years. So what that means is hematocrit will really impact the value of this unit. We went ahead and showed this in this paper, which is in press in Veterinary Clinical Pathology. We went ahead and showed the same thing with using the Precision Extra unit for measuring glucose. It's exactly the same unit, and that paper was published late last year in Journal of Internal Medicine. So I just wanted to share with you some examples. I actually had a lot more there, but time ran away from me. But I just think about how you can use these low-cost, practical point-of-care units on your farm, but beware, have they been validated in cattle, and do they have specific accuracy as assessed by the ROC curve? So with that, thank you very much for your attention.
Thank you, Professor Constable. We've got time for one, maybe 2 quick questions. It's hard for me to see out there with the light, so if someone's... I'm curious about something, Peter. On something like the predicting the time of parturition, you use the ROC curve and you pick what is considered to be the optimal cut point. If you were particularly interested in increasing the sensitivity or the specificity, would it be reasonable to shift that cut point, and could you make it where you were almost sure you wouldn't make a mistake in one direction or the other if that was important?
Yeah, absolutely. The one weakness with the ROC curve, as Dr. Roussel was alluding to, is that we're providing equal weight to sensitivity and specificity, but a lot of the times in diagnostic medicine, we're more interested in ruling in or ruling out a disease. So what is important is that you are provided with the sensitivity, specificity, and those ROC curves, and then from that you can actually shift your cut point yourself to whatever you might exist. You might want to rule out any chance of parturition, or you might want to absolutely capture any chance of parturition. So it makes it a very personal decision.
Walter.
One question about the potassium measurement in plasma regarding interference with total protein. Could you comment on how the potassium measurement with ion selective electrode is in, let's say, dehydrated cows with massively increased protein, or cows that have a subnormal protein concentration? Is there interference to expect?
Thanks very much for that question. Theoretically, yes. When you do a sensitivity analysis, it might be the equivalent of moving the true, so that your measured potassium, let's say, might be 2.8. In reality, it might be 2.9. So the impact on a clinical decision process, to me, is not there. But if you're using it for research, then there might be some impact. But the clinical importance, I don't think it'll change the decision as to whether to give potassium supplementation or not.
Okay, help me thank Dr. Constable one more time for his excellent presentation.